in a couple of seconds. Yes, we are online.
Hey, good morning. I am Fabrice de Genève, the Managing Director of Johnson & Johnson Medical Device, Belgium, Luxembourg, and I'm pleased to open this morning a series of webinars where we will discuss different topics selected by the Belgium Association of Hospital Directors on this unprecedented COVID-19 pandemic. As a leader of a healthcare organization and as a citizen, this unique period has raised so many questions. Hopefully, we'll be able to capture some of them during those sessions. When the COVID-19 outbreak starts, Johnson & Johnson has immediately put in place a crisis management system with 4 pillars. First one was maintaining safety and the support for our employee. Second one was continuity of our supply chain to avoid any disruption for customer and patient. Maintain connection with our surgical staff using remote technology and support hospital when critical surgical procedures were occurring. Of course, accelerate our research for vaccine, and finally, support communities on the hospital. During this live transmission, you will have the possibility to ask questions to the moderator in using the chat tab located on the right-hand side of your screen. Before introducing our speaker, I want to thank the Belgium Association of Hospital Directors for the collaboration and partnership we have developed across the years, resulting today in this dialogue. So let's start this session by introducing our moderator, Professor Pascal Verdonck, Vice President of the Belgium Association of Hospital Directors, and our keynote speaker today, Dr. Paul Stoffels, who is Vice Chair of the Executive Committee and Chief Scientific Officer for Johnson & Johnson. Paul is leading Johnson & Johnson research and product pipeline by leading teams all across our sectors. Native from Belgium, he has studied medicine in Antwerp with a special focus in infectious diseases and tropical medicine. Paul is currently in the forefront of our research team to develop a vaccine. Pascal, the floor is yours in opening this dialogue with Paul today.
Good morning, dear colleagues, especially Dr. Stoffels. Thanks, Fabrice, for the kind invitation. It's a pleasure to have Dr. Stoffels for half an hour, 45 minutes with us. And I'm happy that you're willing to share some insights and some of your experiences. You know, Paul, at New Year, we all wish each other a happy New Year. Some people wish each other a healthy New Year. But this year, nobody was referring to COVID-19, although 19 refers to December 19, the start of the vaccine. And suddenly we were March 11, the World Health Organization announced a pandemic, COVID-19. And now we are confronted with surreal images like empty streets, cities that are not functioning, economy that has started to go in recession. So, like Dr. Janssen always said, what's new? What didn't we learn from previous pandemics at other locations in the world? Was it a surprise for you?
Well, the size and the impact was a surprise. The fact that a new epidemic emerged, not, because we are dealing with epidemics since starting of human mankind, but at least in my time as a physician and working in Africa and working with Janssen, I've seen at least 6-7 of these epidemics evolving, and suddenly one overtakes the world. Yeah, and so in my time, I've lived through HIV, through Ebola. We have worked on Zika. Tuberculosis, we are working on MERS, on Lassa, on Nipah, all viruses which came out of nowhere and suddenly start to cause disease in people. Some were known since long time, like Zika was known since the 50s, and suddenly in Uganda, and suddenly it shows up in South America as causing microcephaly in newborn babies. Yeah, so very surprising situations. MERS is around in the Middle East, transmitted by camels, but also in Korea, South Korea. So viruses emerge around the world. Ebola is now probably more than 25 times it emerged since Peter Piot discovered it in 76, and it's now re-emerged again in Goma a few days ago, while we thought it was over. So surprise, surprise, yes, that it is a coronavirus, and surprise that it's so impactful. We all had expected that influenza would be the virus which would take over the world and would get the 1918 type pandemic. The Minister of Health in the world have been preparing for that. We have been doing research for the last 10 years on vaccines and drugs for treating that. So so it didn't came as a surprise, but it came as a surprise that it was so massive and so impactful.
And you mentioned Corona. Why Corona? Was that not known or is completely new compared to, what is the major difference for non-medics?
Yeah, Corona is not new. There are coronaviruses which cause cold type of disease. So Corona is around. SARS was the first very serious outbreak of a coronavirus, which in Asia, and those who remember, at that moment the world came to a standstill also in Asia. In several countries closed borders, airlines stopped flying. But SARS killed fast and much more people, but it was much less effective on spreading. And they very quickly learned from Ebola that isolation was important. And entire hospitals were isolated at that moment. So in Vietnam, I had a colleague who was working in a hospital, and at a certain point, the hospital, everyone was in, including visitors. The hospital was closed, nobody out for 1 month. Yeah, so including patients, nurses, visitors, everyone had to stay in. They fed the people in the hospital, and until it was over, at that moment they released. So it's not. What's different here is that the transmission mechanism which the virus uses to attack us is extremely efficient in getting into the lower tracts of the lungs, and that's where it can be so severe. And nobody had predicted that. Mm-hmm.
We are 100% sure that it's zoonotic and that it's originated from animal, from scientific point of view.
I think it's like with HIV. People think, can mankind have made such a virus? We would never have been that smart to do it. You never can say never, but it's most likely it comes from zoonosis. There are more than 500 coronaviruses known in bats. The people live very closely together in certain parts of the world with the animals. They eat the soup. In Central Africa, people eat bat soup. Yeah, so they like we take a piece of meat in the soup. They put their bats in the soup. So there is a very close connection, and the likelihood that this jump happened from animals to humans is quite high. So I would not go after any other speculation at this moment until somebody can prove that. It will not help anybody. Yeah.
No, absolutely no. And thanks for your honest answer. About reproduction number and case fatality, can you compare it quantitatively already with the others? Viruses you mentioned and you have experience?
Well, the case fatality is not very high, yeah, and I'm not going to quote numbers on, but
just to have an idea.
But it's not very high, the case fatality, but the spread is massive. If you look at Ebola, the case fatality is extremely high. untreated with no attending physician or nurse, Ebola is north of 90% lethal. If you treat now 50% of people can survive Ebola, but it kills the host so fast that it doesn't have time to spread. So people with Ebola, within the week they get sick, they can't even move anymore, and that's why it was contained very quickly in the regions where it emerged. SARS was much more lethal, but much less transmittable. This is much less lethal, but extremely transmissible, and that's transmitting. And that's where, of course, the number of cases which we see today is huge, but it's also spread to every part of the world now. And yeah, luckily it's not more lethal than we see, because that would give something.
I think in the hospital world we were not yet convinced enough with what happened with Ebola, as it like I said, maybe a turning point in humanity, that could happen in our environment. It's something from Africa and far away, and now we are confronted really nearby. You mentioned correctly, of course, that case fatality is not so high, but nevertheless in Belgium we are confronted with quite a high number of fatalities in the ratio with our inhabitants. That's big discussion, also of the image of our country. And you have already kind of analysis why it's so high, or is that because we have a very good system that counts everything, or whatever?
I think numbers are different in different countries, because the way people are counting, and we count everybody dying in a nursing home today as almost as COVID. I think it's tested or not tested. We know that is at this, let's say, at a higher rate we count. I think honestly, I would say in the end it doesn't matter. We have to take the measures now to make sure it doesn't spread further, faster, and do exactly what's right. We know what we need to do to prevent the transmission, and hopefully with that we can contain it. The sad situation in the nursing homes is very, very daunting for many people who have to cope with that, and I think we have to go to the action on how can we contain it, diagnose. I think diagnostics will have a very important role to track and trace and isolate. And I'll come back to that on how that happened with Ebola. But I've learned several times now in many of these epidemics or pandemics that it came down to while there is no therapy or no vaccine, it comes down to controlling it with diagnostics and isolation. And unfortunately, that's the case. But if you do it well, and you've seen it with SARS, we've seen it with Ebola, we've seen it with Zika, it's very quickly. Zika is a different mode of transmission, but it is doable, but it's a big effort.
No, but please explain what you mentioned, tracking then from Ebola, what you learned from that experience, what can be helpful now after suppression the virus, how we have to continue in the phase we are now in Belgium.
So I've been in many Ebola regions while the epidemic is ongoing, and even in January of this year, I was in Goma and in the Kivu to work with our vaccines in the region where we are vaccinating in Congo now 500,000 people, in Rwanda 200,000 people. But what you see is that even in a developing country, and let me explain what happened in Sierra Leone. In Sierra Leone, Ebola transmits by touching, not by breathing. So, and it's very, very infectious. Ebola has an extreme infectivity, even from surfaces. If you sit in a taxi after an Ebola patient have sitting in there, you could be infected because of the sweat of the people infecting you. So, but what they did was when you walk into a building or into an airport or wherever, your temperature was measured everywhere. So every door had a vessel with bleach water, at the door where you had to wash your hands. There was no handshaking in the whole entire country anymore. But when you had a fever, you were immediately referred to a center to take a blood sample in order to measure it. And let me tell you how intensive it was. So the US military was helping to combat the epidemic. And so when they got aware that in a village somewhere there was to be a possible outbreak, then they sent a team there. And the helicopters of the US military were used to transport the sample immediately to a PCR lab to measure positive or not. Positive, isolate the city, isolate the village, isolate the family, and start vaccinating at that moment with ring vaccination. But isolate the family and isolate the village to make sure that the people who get sick are exported out to a special center. But the military helicopters were used to transport the samples to know very quickly whether people were infected, yes or no. And that helped to isolate those villages with positive cases and not. And by doing that, they got it under control. So it was a track and trace who is infected. First of all, prevention. And on the other hand, track and trace on make sure that the people who you know are infected are isolated very quickly, either treated, and if they are treated and survive, released back in society, but otherwise they were isolated. And the whole region there, Guinea, Liberia, and Sierra Leone could do this because they all implemented this. So in Ebola now in Kivu, it's exactly the same. In SARS in Asia, it was exactly the same. So we can't defy gravity here. We'll have to do what's logic to make sure we do this, and we have to organize ourselves around it. And I think life can start up again to a certain extent, but we have to make sure people understand the rules on what needs to be respected in this to prevent the second big wave of the disease.
What you mentioned with second big wave, can you clarify that for the audience?
And I also learned from the same source as you, from the Belgian television, is that the number of people who have antibodies today is very low. Yeah. So, and for me, surprisingly low. I had thought that many more people would have been infected and would be positive for antibodies. It's surprisingly low. And so we are as vulnerable for this epidemic as before the epidemic started. And I don't think we should not assume that weather and temperature is going to mitigate the virus, going to mitigate the transfection of the infections of the virus. So I think we should be very careful as physicians and as guiders of our teams that we should not live on assumptions. We should just do what's right. Too little people have been exposed and therefore are not immune, and we are at the same point. You have to assume we are at the same point where we were before the epidemic started, that a new introduction could be very, very sad for the whole organization, for the whole country.
That observation, that means that there must be another strategy for herd immunity, because some countries follow the fastest way to herd immunity is to let it go, but
I think you've seen what happened in New York. You have seen what happened in London. I think hoping on herd immunity is far too damaging for society and with very little respect for the individual people. So, if you go for herd immunity, you should expect at least a few deaths in all of your own families. So I absolutely would not choose for that. It is possible to eliminate it by control measures. It should be possible. SARS was eliminated like that. Ebola is eliminated like that. So it should be possible, but it takes discipline and it takes education. Herd immunity can only come with a vaccine on a large scale. I don't think there's anything in between, that you can't go from 2 to 70% hoping that herd immunity will do it. A vaccine should be there, but yeah, the research is still happen, and we even don't know whether a vaccine will work. So don't bet on it yet until we know that it works. Mm-hmm.
I come immediately, of course, to the vaccine. It was a question in between, but just to defend the Belgian approach, I also belong to the people that usually refer to Singapore, but I detected that they also have not problems in their elderly homes, but in dormitories where immigrants came in, and there is also an increase there. So in most systems, some groups escaped a little bit, let's call it from the isolation approach. But of course, what we learn now from your confirmation is that we have a difficult period where isolation and all the hygiene guidelines are very important, and we have to wait for that vaccine. Your company announced some positive news and some light in the tunnel a couple of days ago. Can you clarify a little bit who is looking for a vaccine in the world, to have an overview how many groups or industries are working in it, and what is the connection between them?
Yeah, there are 70. The WHO is people who work with the vaccine work together with the WHO on exchanging information. And I think a few weeks ago there were like 40, but now there are probably already 70 vaccine initiatives. Different technologies are used, and that's important. It's that different pathways are followed to make sure the chance is high enough. So there are, at least as if I know, 6 large pharmaceutical companies who are working on it. You have Chinese companies working on vaccines, and you have several biotech companies. I'd say 10, 20 industrial level vaccine activities are ongoing at the moment, and with shorter and longer timelines. And good that there is different technologies. And we use a vector, an adenovector. I'll come back to that. You have now mRNA, where you inject pieces of RNA or DNA in certain formulations, which then generate the antigen, which then gets the immune reaction. You have proteins, which are used, and basically 4 or 5 different broad strokes of different technologies. All have their benefits and negatives. The benefits of mRNA and the DNA vaccines are that you can go pretty fast, because you can get a piece of DNA quite easily injected in a human with an electroporation. So you need to put a little bit of electricity on the arm, checks, and it goes in. Yeah. So, but what we learned in the past is that it's much less immunogenic, and therefore you need most probably multiple injections. Yeah? So that's being studied in other diseases, but it's a way to do it. The same with mRNA, which is used for cancer vaccines and also for infectious disease vaccines. It goes fast. You can get something done within a few weeks and get to the clinic very fast, but also there, many injections and still very early platforms, which means that you have to stabilize them at -80 Celsius, and you have to transport them to the world at -80 and then bring them to people. So a lot of work still needs to be done on that. What we do is we have adenovectors, which we use since a long time, and we've done Ebola, RSV, Zika, and we are now doing HIV. It's all in experimental. Ebola is the most advanced, which is now submitted with EMA and hopefully gets approved over the summer. But we have vaccinated about 60,000 people so far with the vaccine vector, which gives good safety. We also did all the stability work to keep it long time at -60, then send it around the world -25, and be able to distribute it in the countries at 2 to 8 Celsius, that it can use the normal vaccination system. And so we prepared for that. And 4 times when we used the vaccine, we were able to translate from a virus to an efficacy in animals, and be able to show the same immune responses in humans. And now, in many times, we are validating that in either in challenge models or in real clinical trials. And that's where I can say we are 100% sure we can make it. We are very sure it's going to be safe. and clinical data now have to show whether it prevents infection or whether it prevents disease. So there are two things which we can try to do, is preventing infection or preventing disease. And that will, hopefully we can start, we plan to start clinical trials early September, and hopefully phase 1 in October, and start clinical efficacy studies on a large scale in later in this year, with results early next year. And then I talk about the first quarter next year. In the meantime, Professor, we are starting up manufacturing, and we are building capacity to get 1 billion vaccines produced next year, all at risk. So hopefully we have good outcome, because it's a huge work to produce them, but we can't wait either until the end of the year when we have the clinical data and then start manufacturing. So we will start manufacturing. We are at the moment already preparing for the upscaling later this year, and bringing 1 billion vaccines next year. So
that's a very positive message, but that means that the chance to, because now you call it in your press communication candidate vaccine, you're quite sure that it will be successful, because you start testing on humans and already starting your production facilities and so on. I mean, that's not a simple decision. There must be, I'm looking at the chat and I see a couple of questions are dealing with that. What is the chance to get a vaccine, let's say worldwide?
Well, I think today it's still 50-50. Will it work? Yes or no? Will we be able to create the immunity that it protects for the virus to be able to replicate in the body? We have done that with challenge models in RSV, with healthy volunteers, where we have been able to show that it, and that's the closest it can come. RSV is also a respiratory disease. We have been able to, because there are certain strains which we can use there to do a challenge model. In RSV, we have been able to show that. So we think, I still say 50-50, because we don't understand the virus yet very, very good. We'll know very quickly. We know that in animal models we have neutralizing antibodies. Now we are working on a challenge model, which didn't exist before, an animal challenge model where you vaccinate animals, vaccinate active, vaccinate placebo, then challenge the animals, and that are non-human primates, to see, can you make them sick? And then with the vaccine, can you prevent it? That will give us over the summer some more information on efficacy. But what I said on, I'm sure we can make it. I'm pretty sure it's safe, but it's still 50-50 whether it works, yes or no, in clinical settings. And we think we have a good chance, but the disease is new and we don't know.
Okay, thanks for that clear answer, and it temper a little bit. We're still positive, of course, but okay, it makes us a little bit more realistic, that 50-50. In between, people are always talking about testing. Can, in the transitional phase, and then even it will take a time before people get access to that vaccine. What is your opinion now on testing, and what can we do, especially within our hospitals, but also within our community? From the point of view of testing?
I know we are closely involved in testing with Minister Brabander and the Belgian Cienzano activities. We do at the moment about 3,000 tests a day here in our research. We've set up one of our labs where we do normally clinical testing for clinical trials. We have changed that into a lab which can work as a clinical lab for the country. And I think we could scale up to 10,000 tests a day. Yeah. So if a few others follow and we can get to 40,000-50,000 tests, which is the goal, then we should be able to get everyone who is at risk. If you can test 50,000 people a day, you should be able to serve the primary care doctors, the hospitals, and everyone with fever or who has some kind of symptom. Make sure the test is taken and the test is done, and 24 hours later you know whether the person is positive, yes or no. So I think we should pay much more attention to make sure that we maximize capacity there and then be able to inform the people that they are yes or no positive. And if they are positive, then give them the right instructions and the right opportunity to, like employers, we should make sure we facilitate then, hey, stay at home, isolation, test all your family, make sure you're safe and you're well. We should find a system there to do this as a routine in the country.
So this is one of the priorities nowadays, let's say, in the transition phase to this vaccine period.
Yeah, I think the PCR test to measure whether it's virus at the beginning of when people first have the symptoms, when they are the biggest spreading. It's almost in every viral disease like that, when the virus rages to your body and then you develop the fever. At that moment, we should be able to test people almost on the day and know whether they are infected, yes or no, if people develop fever. And we should train people from. So let me tell what very interesting. So when I came back from Africa into the US with out of Ebola, at the border I was stopped to get first examined, and then I got a telephone from the CDC. And for 1 month, I got a call every morning and every evening from the CDC local nurse who called me to say, measure your fever now and report it to me. Yeah? And so 2 times a day for 1 month, wherever I was in New Jersey, Springhouse, California later on, every time I was followed of where I was, whether I had fever. So these systems on observing, making sure that we follow people. If they have fever, we test them and we make sure that the families are tested in order to indammen, contain the disease. Is the only solution until, not the only distancing and other, but it's an important part of the solution until we can have a vaccine or a drug.
That's a huge opportunity for digital transformation and to follow people at home wherever they are with the new tools. A question is, of course, about once there is a vaccine, how to distribute it among the community. That's not an industry responsibility, but who is responsible for that?
No, I think the governments have to determine how to roll it out, and I think the most logic is that the healthcare workers are the first to get it, in order to make sure they can get safe to work, being confronted with infection every day, and then, if possible, everyone is at risk with any type of immune disease or cancer or immune disease, as well as elderly. I think we should go according to risk groups who die from the disease and make sure that goes first, and then the general population comes afterwards. But that governments have to determine. And that will be also done on a global level. So it's not just us in Belgium who will say what needs to happen. I think global allocation at European level, at global level, at WHO level will happen, I think, for vaccines.
In Europe, we have different health systems. So that, again, will be a complicated matter, I guess.
Yes. It may be some opportunity for getting some systematics into the systems. Yes.
Yeah. Okay. But let's come back to Belgium. Maybe in the last part to talk a little bit about the biggest group that is following this webinar are hospital managers who spend a lot of time, day and night, the last weeks in reorganizing their hospital and motivating the whole team and so on. What would you recommend them? What is important now? What can they do, not only now in the phase that is coming, but also for the near future? Because we will have to be prepared that this can come not only at the end of this year, but next year something else or a variant or whatever. How we have to organize ourselves as hospitals, and what can a hospital leader do in to prepare his organization or her organization for the near future?
Yeah. Well, I can only talk from my experience in other areas, but I think if this doesn't stop soon, it will last long. Yeah. So if we can't get it under control in the next few months, it will last for several years. And if it lasts for several years, we have to build systematics into the problem. And then we go back to what did we do in this country bringing TB under control? Yeah. And so we test people. And when they were positive, we treat them. And when they had to be treated for a long time, we had special hospitals for it. And that's still the case in Africa, yeah, where the XDR and the MDR patients, they are all treated in one hospital so that you don't mix them with other disease. And so and I can only put my 5 cents worth of thinking in it, is like, if there is decent testing and even at the primary care physician level, you would be able to make the triage that this person is positive. Can you send to a place where it's not mixed with other parts? And can you send, and if you go for surgery or for routine surgery, can you do first a test or your negative PCR, and you can go to the hospital where there is no corona, so that there is no risk of I think longer term, if it's this year, we have to make sure we get ourselves organized to make sure we can start up and we can do whatever we need to do. But if this goes on for years, we have to think structurally on how you build it into the system, because mixing the populations in the hospital will not be possible for the next 5 years. I don't think so. I think it has to, and that's a very I can't say this, but many people will probably not agree with this. But if you look on how the big epidemics have been treated in the world, has always been with a vertical approach. Yeah, you go after it and you treat it like that. You can't treat it in a horizontal system in the broader healthcare, and especially not things like TB. Or Zika or HIV. It has been a vertical approach where you go after it, and if we don't do it like that, it will go on and be more trouble than benefit. So I think we have to take a structural approach to it. Short term, make sure we can handle it in one and the same hospital, but long term, if this goes on for long term, we have to much more structural take initiatives to from the basic testing.
What I like in your comment, and it's open for debate, and I see some reactions from colleagues. Mark Knoppen opened a couple of days ago the idea of making COVID, or let's say infectious disease hospitals and non-infectious disease hospitals per province or per network, whatever. And one of the colleagues, Johnny van der Straten, is reacting that in Milan there is one of 800 beds, but it has never been used because there is no trained staff. I was reviewing a paper by accident this weekend from Singapore, where they have such a hospital, an infectious disease hospital next to the standard hospital. And the paper is now an urgent manuscript saying we need to be one hospital with 2 missions. That means it's not possible from an economical point of view to split in different hospitals, and that not all hospitals can infectious disease treating, of course, but you need to have it nearby for trained staff, for capacity, for collaboration, and so on. Did you see things like that in your view worldwide?
Yeah, I see. If you go to Durban, and there you have at King Zulu Hospital, which is one building on a big campus, which is totally devoted to X and MDR. So 600 beds who are devoted to that, and they are in a campus setting where they can access different capabilities, but at least the people are isolated. You have trained staff because they are much better trained, much better experienced in what they have to do. So it becomes a systematic that you don't mix them in one building. You bring people together in one building where you have, if you look at your orthopedic centers today, you don't do surgery in areas where there is multi-drug resistant bacteria. Yeah, because why not? Because you don't want to contaminate. So there is a certain logic in how do you deal with infectious diseases. We are not used to it anymore because it's not that critical over the last 10 years, but in most of the African areas you have for HIV, you have special hospitals, not because you want to isolate the patient. They are not, HIV people are not infective by meeting or by shaking hands or whatever, but you want a specialty and you want to get organized to do that efficiently with very specialty docs. So, but here the risk of infection is big. So I think if you can, in cities where you have 15 hospitals or 10 hospitals, can one be the one which is dedicated to this? And it's such an economic damage at the moment to the country and to the people of the country that having a special effort to finance those places very well to make sure that they function and they give an added value to the entire society, I think is absolutely worth for society to do it.
But this must be a collaboration between government, the hospital sector, and industry to do the right investments at the right spots.
I think so. And what we discussed before, when is last year when I think we spoke in Ghent, is I think the more we can use the brain capacity of the senior leaders of the hospital sector, as well as industry, as well as the government, is to together solve this. Yeah. Because the know-how is in your systems, in your organizations. You know how you can set up in order to prevent and to change the course of this pandemic by how to manage the hospitals. I think we shouldn't wait only for politics, for the politician, and I'm sure you don't, but to solve this. But today there is still, I think, hope that it's over quickly. Yeah, I think we should not live on hope. We should plan, and that is we should plan for the worst and hope for the best, and that is, I think, at the moment the better solution for this disease as it evolves and as we can expect it could come back. We should not hope that this is over by the. We should plan for that this is not over next year, but we should hope that we can wish each other happy New Year and healthy New Year at the end of the year. Yeah, but we are not sure of that yet.
Okay, with that beautiful message and words of hope, and also inspiring for activity and implicitly asking for entrepreneurial leadership of our CEOs and CMOs, I'd like to thank on behalf of the community for the time and to share with us today your insights and experience. And I wish you all the luck in your own company with all the big plans you have started up. And we look forward to, of course, a treatment and a solution for this disease and other diseases. And I give the floor back to Fabrice. Thank you, Dr. Stoffels.
Thank you.
So as we are closing this first webinar, I would like to thank Professor Pascal Verdonck for moderating this insightful dialogue with Dr. Paul Stoffels, for sharing his thoughts for our upcoming journey before the vaccine is available. And finally, I would like to thank you, all of you, make the time available for this webinar session. And on behalf of Johnson & Johnson as well, we'd like to thank all your staff for the amazing job you've been doing since the pandemic start. We are so grateful that you're doing that for the benefit of all of us. And finally, we'll connect again. So as you can see on the screen, that we're going to continue this series of webinar with a new topic who has been shared by you. And the next one will be scheduled on the 5th of May, supporting frontline during COVID-19. And we're going to learn from Belgium, Netherlands, and Italy. And the next one will be on the 7th. It's a Thursday, not Wednesday. And we're going to discuss about our COVID-19 crisis offering the momentum to reset the button. And hopefully, we're going to use this unique moment to transform healthcare for the better. Thank you very much for attending, and I wish you a great day.
Thank you. Bye-bye.
Thank you.